Good afternoon for all beautiful people, and today we are having the second lecture in hematology course, and the topic is acute and chronic leukemias. So let's remind you that all hematopoiesis usually starts from blood stem cell, which then should be differentiated to myeloid and lymphoid stem cells. Each of these gives birth for several blood cells. So if we talk about myeloid germ, at the end, we will receive red blood cells, platelets, and granulocytes. Lymphoid stem cell gives only lymphoblast derivatives, and they are B and T lymphocyte and natural killer cell, comparing with the myeloid one. Leukemia, a cancer of the blood-forming tissues characterized by large increase in the numbers of the white blood cells in the circulation or the bone marrow. In general, quantity of the blood disorders, malignant blood disorders, leukemia takes around 34%. The biggest part of the cases of the blood cancer is taken by lymphoma. It's almost 50%, so half of the all cases. And around 20%, usually it's a myeloma problem. There are several types of leukemia. We can distinguish actually acute and the chronic leukemias, and according to the germ of production or the type of the blood cell production, it can be or lymphoblastic or myelogenous leukemia. So in total, we have 4 different types of leukemia: acute lymphoblastic or myelogenous leukemia, and the chronic lymphoblastic and myelogenous leukemia. In total, lymphoblastic leukemia, if we talk about acute one, is all problem mostly of the children, comparing with other 3 types, which are represented adult population of patients, and acute myelogenous can be seen in children, but in smaller percentage of cases comparing with adult patients population. How to divide clinical acute and chronic leukemias? If we talk about acute leukemias, it's usually a rapid onset, and disorder and diagnosis of the disorder will be based on aggressive symptomatic of the disorder, which appears in short period of time. Usually it's malignant onset of the disease and malignant course of the disease. And curability, yes, it's potential, but it doesn't give any, I would say, promises to be cured. In chronic leukemias, usually this diagnosis can be found during general observation of the patient who has no symptom at all, or can have some complaints, for example, cardiovascular disorders or probably pulmonary disorders, such as, for example, dyspnea, weakness, etc. And during observation, the patient can be found a diagnosis of chronic leukemia, curability less suggestive than or less potential than in acute types, but there are some cases. Also, patient can be referred to physician for observation with such symptoms as general weakness, subfebrile temperature. Sometimes it's a long cough or dyspnea for unknown reason, etc. But there is no acute symptom. There is no hypertension, hyperthermia, of fever with high numbers of the temperature. There is no, for example, kidney failure, and etc. Comparing with acute leukemias. Acute myelogenous leukemia is a clonal malignant disease of hematopoietic tissues that is characterized by, first, its accumulation of abnormal blast cells, principally in the bone marrow, and the second one, impaired production of normal blood cells. Leukemic cell infiltration in marrow is accompanied nearly invariably by anemia and thrombocytopenia. The absolute neutrophil count may be low or normal, depending on the total white cell count. The first well-documented case of this disorder is attributed to Friedreich, but Epstein was the first to use the term acute leukemia in 1889. This work led to general appreciation of the clinical distinction between acute myelogenous leukemia and the chronic myelogenous leukemia. Most of the cases are idiopathic, genetic predisposition, radiation, chemical or other occupational exposures, and drugs have been implicated in the development of this disease. But this type of leukemia cases with established etiology are relatively rare. No direct evidence suggests a viral etiology. Genome sequencing studies suggest that the most cases of myeloid acute leukemia arise from a limited number of mutations that accumulate with advancing age. Myeloid neoplasm typically occurs sporadically in adults. Inherited predisposition rare, and myeloid neoplasm with germline predisposition represent an important and growing subset of disease. Several genetic syndromes with somatic cell chromosome aneuploidy, such as Down syndrome with trisomy 21, are associated with the increased evidence of acute myeloid leukemia. Anti-cancer drugs are the leading cause of the therapy-associated disease. Unkilling agent-associated leukemias occur on average from 4 to 6 years after exposure to iodine radiation. Benzene, chloramchenol, phenylbutazone, and other drugs can commonly result in bone marrow failure. The current categorization of acute myeloid leukemia uses the World Health Organization classification, which defines biological distinct groups based on cytogenic and molecular abnormalities, in addition to clinical features and light microscope morphology. This type of leukemia is the predominant form of leukemia during the neonatal period, but represents a small proportion of cases during childhood and adolescence. It accounts for 15 to 20% of the acute leukemias in children and 80% of the acute leukemias in adults. It's slightly more common in males. Little difference in incidence is seen between individuals of African or European descent at any age. Let's talk about pathogenesis. So this type of leukemia results from a series of somatic mutation in a primitive hematopoietic multipotential progenitor cell, or very occasionally more differentiated, more lineage-restricted progenitor cell. Because the T lymphocytes, B lymphocytes, a natural killer cell in cases of the acute myeloid leukemia, often have not carried a cytogenic abnormality as did the myeloid cells, claims of origin in the pluripotential hematopoietic cell have been ambitious. The most compelling data indicate the bulk of acute myeloid leukemia cases arise from the one of two predominant CD34 cell population, and CD means cluster of differentiation. That means that each cluster has the different molecules, so based on which we can differentiate them during immunological studies. So CD34 has 34 molecular number. Also, CD not only 34 but 45 array, 38 and 90, which represents multipotential myeloid progenitor, or CD4, 38, 45 array, and 110, which represents granulocyte monocyte progenitor. Both of these cell population corresponds to normal hematopoietic progenitor cell. and not the normal pluripotential hematopoietic stem cell. Because progenitor cell are not self-renewing, the somatic mutation transformed the normal progenitor cell to acute myeloid leukemia stem cell capable of sustaining the disease. Some cases of this disorder can arise from the accumulation of genetic and epigenetic changes in normal pluripotential hematopoietic stem cell. Genome sequences in acute myeloid leukemia cells show that the most of mutation occur at random before acquisition of the initiation driver mutation, giving each clone a mutational history. The founding clone may acquire additional mutations, yielding subclones that contribute to disease progression or release. When copy number aberrations and copy neutral loss of heterogeneity gene mutation profiles are analyzed in these leukemia cases, a diagnosis at relapse, the relapse leukemia always reflects reemergence of the founder clone. In persistent leukemia cases, sometimes two coexisting dominant clones can be seen, one chemotherapy sensitive and one chemotherapy resistant. Acute myeloid leukemia with multiple chromosome aberration is always characterized by the critically short telomeres. Leukemic cells show variable production in length of telemetric DNA, and telomere length in blood cells during remission is greater. Somatic mutation results from a chromosomal translocation, which results in a rearrangement of a clinical region of pro-oncogene. Fusion of portions of two genes often does not prevent the process of transcription and translation. The mutant protein product often is a transcription factor or an element in the transcription pathway that disrupts the regulatory sequences controlling growth rate or survival of the blood cell progenitor and their differentiation and maturation. The mutation in acute myeloid leukemia results in deregulation of any several signal transduction pathways, which disrupt pathways to ensure the normal behavior of differentiation and maturation, proliferation, and survival signals in hematopoietic cells. Signs and symptoms that signal the onset of acute myeloid leukemia include pallor, fatigue, weakness, palpitation, and dyspnea on exertion. The signs and symptoms reflect the development of anemia. However, weakness, loss of sense of well-being, and fatigue on exertion can be disproportionate to the severity of anemia. Easy bruising, petechiae, petexis, gingival bleeding, conjunctival hemorrhages, and prolonged bleeding from skin injuries reflect thrombocytopenia and a frequent early manifestation of the disease. Apparent frequently gastrointestinal, genitourinary, bronchopulmonary, or central nervous system bleeding occurs at the onset of disease. Pustules or other minor pyogenic infection of the skin and of minor cuts or wounds are most common. Major injections such as sinusitis, pneumonia, pyelonephritis, and meningitis are uncommon, representing features of the disease, partly because of absolute neutrophil count less than 0.5 in the liter are common until the chemotherapy starts. Anorexia and weight loss are frequent findings. Fever is present in many patients at the time of diagnosis. Palpable splenomegaly or hepatomegaly occurs in approximately 1/4 of the patients. Lymphadenopathy is extremely uncommon except the monocytic variant of acute myeloid leukemia. Skin involvement may be of three types: non-specific lesions, leukemia cutis, or granulocytic sarcoma of skin and subcutis. Non-specific lesions include macules, papules, vesicles, pyoderma gangrenosum, vasculitis, neutrophilic dermatitis or sweet syndrome. You can see it on the picture at the right side of the screen. Cutis, verticals gyrata, and erythema multiforme or nodosum. Skin involvement preceding marrow and blood involvement overlaps occurs, but it's rare. Sensory organ involvement is very unusual, but retinal, choroidal, iridial, and optic nerve infiltration can occur. Otitis externa and interna in the ear, hemorrhage, and mastoid tumors with the seventh nerve involvement may be present in signs. The gastrointestinal tract may be involved at any point, but functional disturbance is unusual. The mouth, colon, and anal canal are sites of involvement that they mostly lead to symptoms. Oral manifestation may prompt the patient to visit the dentist. Gingival and periodontal infiltration and dental abscess may lead to an extraction, followed by prolonged bleeding of an infected tooth socket. Fever, abdominal pain, bloody diarrhea, or ileus may be present and occasionally mimic appendicitis. Intestinal perforation and inflammatory mass-associated infection with the enterogram-negative bacilli and or Clostridial species, often associated with a fatal outcome. Isolated involvement of the gastrointestinal tract is rare. The respiratory tract can be involved by infiltrates or tumors, leading to laryngeal obstruction, parenchymal infiltrates, alveolar septal infiltration, or pleural sealing. Cardiac involvement is frequently rare, causes symptoms. Symptomatic pericarditis infiltrates, transmural ventricular infiltrates with hemorrhage and endocardial foci with associated intracavitary thrombi can occasionally cause heart failure, arrhythmia, and death. Infiltration of the conducting system of valve leaflets or myocardial infarction has occurred. The urogenital system can be affected. The kidneys are infiltrated with leukemic cells in a high proportion of cases, but functional abnormalities are rare. Hemorrhage in the pelvis or collecting system is frequent. Osteoarticular symptoms may occur. Bone pain, joint pain, and bone necrosis can occur, and rarely arthritis with effusion is present. Crystal-induced arthritis or either calcium pyrophosphate dehydrate, pseudogout, or monosodium urate gout may be representable by the synovitis in some cases. Central or peripheral nervous system involvement by infiltration of leukemic cells is very uncommon. Also, meningeal involvement is an important consideration of the treatment of the monocytic type of leukemia. Myeloid sarcoma, other names of it, granulocytic sarcoma, chloroma, myeloblastoma, or monocytoma, is a tumor composed of myeloblasts, monoblasts, and megakaryocytes. The tumor may cure an extramedullary mass without evidence of leukemia in the blood or marrow, so-called non-leukemic myeloid sarcomas, or in association with acute myeloid leukemia. It's, as you can understand, in case of appearance of myeloid sarcoma, it's malignant course of the disorder, which probably not curable at all or hardly curable. Anemia is the most constant feature of the CBC and the blood smear in case of this leukemia type. Red cell lifespan can be mildly shortened, but the principal cause of anemia is inadequate production of the red cells. I should remind you that the red cells appears from the same progenitor as the platelets and the granulocytes, and we are talking about this progenitor problems. Yeah, it's Myelogenous germ. The reticulocyte count usually between 0.5 and 2%. Occasionally, patients with rapid destruction of autologous and transfused red cells as a result of unknown mechanism referred to as milieuhemolysis. The presence of the red cells autoantibodies, positive direct antiglobulin test is useful in this case, is very uncommon. Thrombocytopenia is nearly always present at the time of diagnosis. The mechanism of thrombocytopenia is a combination of inadequate production and decreased survival of platelets. More than half of the patients have platelets count less than 50 and normal one 150 until 300 at the time of diagnosis. The total leukocyte count is less than 5 and approximately half of the patients at the time of the diagnosis. The absolute neutrophil count is less than 1 milliliter in more than half of the cases at diagnosis. Patients with a very elevated total leukocyte count have a low proportion of mature neutrophils, but may have a normal absolute neutrophil count. Hypersegmented, hyposegmented, and hypogranular mature neutrophils may be present. Cytochemical abnormalities of the blood neutrophils include low or absent myeloperoxidase or low alkaline phosphatase activity. Defects in phagocytosis or microbial killing are common. Myeloblasts most always are present in the blood, but may be infrequent in several leukopenic patients. Classic leukemic blast cells are agranular, but mixtures of the mature cells, including agranular and slightly granular cells, ranging up to that progranulocytes, can occur. Our rods are elliptical cytoplasmic inclusion, approximately 1 to 1.5 nanometers long and 0.5 wide, that derive from azurophilic granules. Presence of our rods suggests the patient has relapse of the disorder, and the treatment of the patient wasn't successful. Serum uric acid and lactic dehydrogenase levels are higher in myelomonocytic and monocytic acute myeloid leukemia than in other phenotypes. Occasional patients have very elevated uric acid levels, which usually occur after chemotherapy if proper precautions are not taken. Abnormalities of sodium, potassium, calcium, or hydrogen ion concentration are infrequently and usually mild. Severe hyponatremia associated with inappropriate antidiuretic hormone secretion has occurred at presentation. Severe hyponatremia as a consequence of diabetes insipidus can be an initial event. Hypokalemia is more frequent finding in presentation and is related to cholestasis, although the reason for the proximal renal tubular dysfunction is unclear. Factitious elevation in the serum potassium level have been reported in patients with hyperleukocytosis as a result of leakage from white cells in vitro. The presence of hypercalcemia is multifactorial, but cases with increased ectopic parathyroid-like activity in the plasma have been described. Severe lactic acidosis prior to treatment have been reported. Hypophosphatemia as a result of phosphate uptake by leukemic cells can occur. Also, prothrombin and partial thromboplastin times usually are normal or near normal. Abnormal concentration of coagulation factors are frequent. Elevation of platelet factor 4 and thromboxane B2 occur often. Decreases of alpha-2 antiplasmin, protein C, and antithrombin 3 levels are frequent and may be associated with venous thrombosis. Aspiration and biopsy of the bone marrow, usually from the superior posterior iliac crest, is routinely performed by the hematologist to confirm the diagnosis of acute leukemia. Aspirate samples are sent for morphologic, histochemical, immunophenotypic, cytogenetic, and molecular analysis to enable classification of the leukemia. The threshold number of blasts in the bone marrow is 20% and more. Exceptions include acute myeloid leukemia with trisomy 8 to 21, involvement of 16 chromosome, trisomy 15 to 17, in which the diagnosis of myeloid leukemia is made regardless of the percentage of the bone marrow blast due to changes in the chromosome character. Obtain the fresh bone marrow aspirate aspirate should be obtained for all patients suspected of acute leukemia, a portion of which should be used to make aspirate specimen for morphologic evaluation. If performed, the pathologist should evaluate an adequate bone marrow troponin core biopsy, touch preparation, and marrow clots in conjunction with the bone marrow aspirates. The marrow always contains leukemic blood cells. In case of acute myeloid leukemia, from 3 to 95% of marrow cells are blasted at the time of diagnosis or relapse. Myeloblasts are distinguished from lymphoblasts by any of three pathognomic features: reactivity with specific histochemical stains, our rods in the cells, or activity with the panel of monoclonal antibodies against epitope present on myoblasts. Our rods in the cells suggest that cell is young and non-mature, so there's problem of differentiation of the cells. Normal erythropoiesis, megakaryocytopoiesis, and granulopoiesis are decreased or absent in the marrow aspirate. The biopsy may contain residual islands of erythroblasts or megakaryocytes. Dysmorphic changes in hematopoietic cells, including very small or large erythroblasts with nuclear fragmentation or binucleation or delayed nuclear consideration. Increased blood vessel density or increased angiogenesis is present in the marrow of the patients with acute myeloid leukemia compared to normal subjects. An abnormal number, or called aneuploidy, or structure pseudodiploploidy of chromosomes, or both, are evident in approximately 55% of cases of acute myeloid leukemia. The most prevalent abnormalities are trisomy 8, monosomy 7, monosomy 21, trisomy 21, and loss of X or Y chromosome. However, any chromosome can be rearranged, added, or lost. The trisomy 8 to 21 and inversion of 16 confer a more favorable outcome on average. Trisomy 15 to 17 converts of highly favorable prognosis. Approximately 45% of cases contain cells that are cytogenically normal. Approximately 2% of patients have the Philadelphia chromosome in a significant proportion of leukemic blood cells. The blood cells have surface antigens such as CD13 and CD33, characteristic of myeloid leukemias. One interpretation of the concurrence of acute myeloid leukemia with trisomy 9 to 22 is that it represents chronic myeloid leukemia presenting in myeloid blast crisis. As you can see in the picture, normal chromosome in complete remission is seen on the picture upper part of in the upper part of the slide, and the lower part of the slide you see trisomy 8 to 21. The karyotype at diagnosis was and as the only cytogenetic change and translocation. This type of translocation usually seen in acute myeloid leukemia. Type M2, often associated with the outer rods, appearance, marrow eosinophilia, and favorable prognosis means the treatment can be successful in this case. The immunophenotype of the bone marrow cells is determined using monoclonal antibodies that recognize myeloid and lymphoid-specific glycoprotein antigens, referred to as cluster of differentiation, or as we already discussed, CD, on the surface of normal and leukemic hematopoietic cells. Acute myeloid leukemia usually express the following immunotypes itself: CD13, 15, and 33. Monocytoid AML cells with cluster of differentiation 14, and blast cells, all lineages with clusters of differentiation 34. Based on morphology, was created morphological classification, which is based on the identification of the leukemia cell line and its stages of differentiation. The first microscopic description, dating from 1930s, pointed to two different types of leukemia cells, lymphoid and myeloid. In 1976, the consequences that lead to the French-American British classification was achieved. Now it's like old classification of leukemia types, morphological types, but still is useful and can be used for leukemia differentiation. It includes criteria for identifying myeloid and lymphoid leukemia and gives a list of morphological subtypes describing how this affects the patient's prognosis. So if we are talking about acute myeloblastic leukemia, we can divide 7 types of leukemia, which is represented by the numbers from M0 to M7. So let's talk about more precisely about them. Yep. Acute myeloblastic leukemia, approximately 25% of all acute myeloid leukemia cases represents and have features of acute myeloblastic leukemia, a variant in which the leukemic myeloblast is the predominant cell in the marrow. Acute myeloblastic leukemia was divided into two forms, designated by M0 and 1 in morphological classification. The blast react with the antibodies to myeloperoxidase and antibodies to CD13, 33, and 34. Human leukocyte antigen is positive in the most patients. Acute myelomonocytic leukemia takes approximately 15% of the patient with myeloid leukemia, represents with this variant, and they are more likely to have extramedullary infiltrates in gingiva, skin, the central nervous system than are patients with acute myeloblastic leukemia in total. A mixture of myeloblast and monoblast is found in the blood and marrow. This variant represented as M4 in FAB classification and as acute myelomonocytic leukemia in the WHO classification. Translocation involving chromosome 3 is associated with this phenotype. Acute erythroid leukemia makes up approximately 5% of all cases and referred as M6 in the morphology classification. Familial erythroleukemia have been described. Erythroid leukemia is arbitrarily divided into 3 degrees of severity. First, it's erythroleukemia, in which more than 50% of the marrow are dysmorphic. The second, erythroblast mixed with myeloblast, and third, a form of which dysmorphic erythroblasts dominate the marrow, pure erythroid leukemia called. The erythroid leukemias are characterized by a striking population of dysmorphic erythroblasts and marrow and red cell in the blood. Acute promyelocytic leukemia, this variant called as a type M3 in the morphological classification, and acute promyelocytic leukemia in the WHO classification occurs at any age and constitutes approximately 7% of all leukemia cases. Occurs with the greater frequency among Latinos from Europe and South and Central America. Hemorrhagic manifestations are prominent, including hemoptysis, hematuria, vaginal bleeding, melena, hematometasis, and pulmonary and intracranial bleeding, as well as the more typical skin and mucous membrane bleeding. In severity leukopenic patients, blast may not be evident in the blood. Acute monocytic leukemia, approximately 8% of all patients presented with this type of leukemia, referred as M5 type by morphological classification. Patients with monocytic leukemia have a high prevalence of extramedullary tumors of the skin, gingiva, eyes, larynx, lung, rectum, and anal canal, bladder, lymph nodes, meningitis, central nervous system, and other sites, than do other phenotypes. The proportion of monocytic cell is greater than 75%. The total count is high in a large proportion of the patient, and hyperleukocytosis occur more frequently. Acute eosinophilic leukemia is rare. Increased eosinophils in the marrow, but not in the blood, is a variant of acute myelomonocytic leukemia and inversion of 16 and other abnormalities of chromosome 16, but is not considered as acute eosinophilic leukemia. Anemia, thrombocytopenia, and blast cells in the blood and marrow are present. Eosinophilic cells are dysmorphic, and the cytoplasm are hypergranulated with smaller than normal eosinophilic granules. Hepatomegaly, splenomegaly, and lymphadenopathy are more common than other variants of this of the myeloid leukemia in total. Acute megakardioblastic leukemia firstly was reported in 1963 with the help of Jour and Lewis. They reported a patient with pancytopenia, low percentage of blood cells, and intense myelofibrosis, but an absence of teardrop red cells, splenomegaly, leukocytosis, and thrombocytosis, the usual features of primary myelofibrosis. This leukemia is referred as M7 type in morphological classification. Leukemic megakardioblasts and promegakaryocytes can be difficult to identify by light microscopy using polychrome staining. The marrow sometimes cannot be aspirated because of intense myelofibrosis. It's probably one of the most malignant types of leukemia. Acute basophilic and mast cell leukemia presented in approximately 1 in 100 cases of acute myeloid leukemia. Basophilic differentiation is the future of this leukemia. Is the future of acute myeloid leukemias in general is an uncommon event. The cell stain, which tolerated in blue, and the basophilic granules can be most striking in myelocytes. Anemia, thrombocytopenia, and blast cells in the blood are present at the time of diagnosis. The blood leukocyte count usually is elevated. The proportion of the cells are basophils. The marrow is cellular with a high proportion of blasts and early and late basophilic myelocytes. Presence of CD9, CD25, or both is characteristic of basophilic differentiation. Differential diagnosis should be made with several disorders that have the very common signs and symptoms. With acute myelogenous leukemia in adults, the term pseudoleukemia have been applied to circumstances that mimic the marrow appearance of promyelocytic leukemia. In pseudoleukemia, the platelet count may be normal. The degree of leukemia is more profound than usually seen in acute myeloid leukemias. Promyelocytes contain a prominent paranuclear clear zone not covered with the granules, and promyelocytes do not have our rods. Similar reactions have been reported with after-granulocyte colony stimulating factor administration. In patients with hypoplastic marrows, careful examination of specimen is required to distinguish monoplastic anemia, hypoplastic acute leukemia, and hypoplastic oligoblastic myelogenous leukemia. Leukemic blood cells are evident in the marrow in hypoplastic leukemia, and islands of dysmorphic cells, especially megakaryocytes, are present in hypoplastic oligoblastic leukemia. Leukemioid reaction and non-leukemic pancytopenias can be distinguished from acute myeloid leukemia by the absence of leukemic blood cells in the blood or marrow. A leukemioid reaction is marked granulocytic leukocytosis produced by normal bone marrow in response to systemic infection or cancer. Also, not a neoplastic disorder and leukemioid reaction with very high white blood cells count may require testing to distinguish it from chronic myeloid leukemia. The usual treatment of this type of leukemia includes an initial program termed the induction phase. Induction may involve the simultaneous use of multiple agents or planned sequence of therapy called time sequential treatment. Once a remission is obtained, further treatment is indicated to preserve the remission state. Remission is defined as elimination of the leukemic cell population in the marrow judged by microscopy and flow cytometry, and the restitution of the marrow hematopoiesis resulting in normal or virtually normal blood cell, hemoglobin, and the platelet concentration of the blood. Remission is based on the number of the blast cell, which should be not more than 5%, and in the absence of our rods in granulocytic cells. The post-induction treatment can consist of cytotoxic chemotherapy, stem cell transplantation, or lower dose maintenance chemotherapy, depending upon the patient performance status and risk factor. If relapse occurs, treatment options may include different chemotherapy regimens, allogeneic stem cell transplantation, or other investigational regimens, often as a part of the clinical trial. Most patients should be advised to undergo treatment promptly after diagnosis. Patients younger than 60 years of age have a poor outcome at the time from diagnosis to treatment length. Pre-treatment laboratory examination should include blood cell count, cytochemistry analysis, and immunophenotyping or leukemic cells from blood or marrow. Marrow examination including cytogenetic and molecular analysis to include several mutations if available. If these are not available, they can be performed later as required based on the subtype of myeloid leukemia from a cryopreserved specimen. Blood chemistry studies, chest radiography, electrocardiogram, and determination of the partial thromboplastin time, prothrombin time, and fibrinogen levels should be obtained. More extensive evaluation of coagulation factors should be made if clotting times are abnormal, bleeding is exaggerated for the level of the platelet count, and acute monocytic leukemia is the phenotype. Various acceptable induction regimens are available for the therapy in the younger patient or older fit patient. Fit means the patient is stable and have a classical, actually clinical picture of the leukemia, and not only clinical but bone marrow and CBC pictures. The most common approach is 3 and 7, consists of 3 days of 15 to 30 minute infusion of anthracycline or anthracycline combined with the cytarabine as a 24-hour infusion daily for 7 days. Traditional dosage have been as follows: cytarabine 20 milligram by square meter of the body surface by day for 3 days. Daunorubicin 45 to 90 milligram on the square meter of the body surface in day for 3 days. And mitoxantron 20 milligram on the square meter of the body surface a day for 3 days. These regimens require adequate cardiac, hepatic, and renal function. On these regimens, approximately 50% of patients achieve remission with the one course. Another 10 to 15% of patients enter remission after a second course of the therapy. Most patients younger than 60 years old should be evaluated for allogeneic stem cell and transplantation. Exceptions include patients with the favorable cytogenic and molecular markers and those with significant comorbidities. Other options for post-remission therapy include further chemotherapy and rarely autologous stem cell transplantation. Mayer and others conducted the randomized study of 3 different doses of cytarabine in patients with acute myeloid leukemia who achieved remission after standard 3 and 7 induction chemotherapy. Patients received 4 courses of cytarabine and only one of following dosage. One of the following dosages: 100, 400, or 3 grams on the square meter. And the result was actually more prominent than the classic therapy. The American Society of the Blood and Marrow Transplantation considers that in patients with acute myeloid leukemia who are under the age of 55, allogeneic stem cell transplantation offers no survival of advantages for those with low risk cytogenetics who are in the first clinical remission, but does offer survival advantages versus chemotherapy for those with the high risk cytogenetics. Before referral for allogeneic stem cell production, a suitable donor must be identified, of course. Ideally, this is a fully human leukocyte antigen matched sibling. However, many patients do not have such donors. So in those patient alternatives include transplantation using a matched unrelated donor or using cord blood if available. In remission, induction therapy principle consists of 2 tenets. The competent population of cells are present in the marrow, normal polyclonal and leukemic monoclonal population, and profound suppression of the leukemic cells to the point they are inapparent in the marrow aspirate, and biopsy is required to permit restoration of polyclonal hematopoiesis. Although these 2 principles hold in most cases, 2 deviations from these guidelines are that it's a predisposition of patient to enter remission despite cellular post-therapy marrow, and the rare presence of monoclonal hematopoiesis in some cases during remission. Goal of induction therapy is achievement of complete remission, less than 2% blast in the marrow, and neutrophil count greater than 1,000 nanoliter, and platelet greater than 100,000 nanoliter. For older adults with newly diagnosed acute myeloid leukemia, consider candidates for intensive anti-leukemic therapy. Over less intensive anti-leukemic therapy is suggested. Treatment should be given only in specialized medical centers A possible curative treatment includes induction chemotherapy, post-remission therapy, and in moderate to high-risk patient, possible allogeneic stem cell transplantation. All transretinoid acid should be started immediately if a special type of leukemia is suspected. Post-remission therapy includes several types of therapy. One of them is cytotoxic therapy. Post-remission therapy is intended to prolong remission duration and overall survival, but no consensus exists regarding the best approach. Does not produce profound prolonged cytopenias, closely simulating intense induction therapy, has produced an average on a slight prolongation of remission of life. Regimens that fall between these intensities have been used with equivocal results. Intensive consolidation therapy after remission results in somewhat longer remission duration and, more significantly, a subset of patients who have a remission of more than 3 years. The decision to utilize autologous or allogeneic stem cell transplantation or high-dose cytarabine alone for consideration should be individualized based on the patient's age and other prognostic factors, such as high-risk cytogenetic findings and antecedent hematological disease. Intensive consolidation therapy for patients who do not have high-dose chemotherapy with autologous or allogeneic transplantation in the first remission consolidation regimen containing high-dosage cytarabine provide a better result than immediate dose cytarabine intermediate. With these regimens are not universally accepted. Patients who are to have allogeneic stem cell transplantation do not require a cycle of high dosage of cytarabine and may not benefit from even one, if a donor is readily available. RAS mutation are associated with benefit from high-dose cytarabine therapy. RAS mutation as a BRAS and CRAS mutation, they should be evaluated because they give an understanding of malignancy of disease. The more malignant, for example, RAS mutation has high benefits from high dosages of cytarabine, as in case of presence of RAS mutation, the neoplastic disorder is more malignant and can actually, no, not in case of leukemia, mostly in case of the cancer, can, metastase more frequently than other types. So various forms of less intensive maintenance chemotherapy have been attempted after completion of intense consolidation chemotherapy, and many of the regimens consist of monthly chemotherapy, for example, low doses of 6-thioguanine or cytarabine. Autologous stem cell infusion after myeloblastic chemotherapy or chemoradiotherapy for consolidation consists of full intensity transplantation. The patient is prepared with a regimen that includes total body radiation and or high dose chemotherapy, after which the donor stem cells are infused by vein. Patient given allogeneic blood stem cell will have more rapid transpoetic reconstitution than patient given marrow stem cell, but they may have more chronic complication and comparable risk of relapse. Medication used for additional treatment in patients with acute myeloid leukemia represented by antineoplastic agents that are used for induction or consolidation therapy. This agent inhibits cell growth and differentiation. They include cytarabine, daunorubicin, idarubicin, and methoxantron. Also, patient can be treated by neoplastic tyrosine kinase inhibitors that target a specific type of mutation. And for example of this disorder this drugs is midostaurin, and its major active metabolites inhibit receptor signaling and cell proliferation by inhibition of this signaling receptor, and induce apoptosis in leukemic cells. It's indicated in combination with standard cytarabine and daunorubicin indication and cytarabine consolidation therapy for adults with newly diagnosed acute myeloid leukemia. Other presenter of this type of drugs is gilteritinib, inhibits multiple receptor tyrosine kinase, including FMS like tyrosine kinase 3, that leads to decreasing of cell proliferation and induced apoptosis of abnormal cells. Antineoplastic Hedgehog pathway inhibitors, smooth inhibition of Hedgehog signaling impacts tumor biology by disrupting the regulation of cancer stem cell survival. This may inhibit development of the drug-resistant and prevent relapse. BCL2 inhibitor of expression of this type of molecule have been demonstrated in the acute myeloid cells, where it mediates tumor cell survival and has been associated with the resistance to chemotherapeutic agents. A representative of this drug class named venetoclax helps restore the process of apoptosis by binding directly to this protein. It indicates for newly diagnosed acute myeloid leukemia in adults aged 75 years and older, or adults who have comorbidities that preclude use of intense induction chemotherapy. IVth inhibitors or inhibitors of isocitrate dehydrogenase demonstrates decreases of 2-hydroxyl-glutarate levels and induced myeloid differentiation in vitro and in vivo in mouse with the actually mutated acute myeloid leukemia. Representer enazidenib targets mutant IDH2 variants indicated for adults which relapsed or refractory mutated acute myeloid leukemia. Generally, all medication used for treatment are targeted to stop cell proliferation, to induce apoptosis, or to include or to disrupt abnormal production of broken DNA in the marrow cells. So another type of leukemia we'll talk in this lecture is chronic myelogenous leukemia, also known as chronic myeloid leukemia. Is a myeloproliferative disorder characterized by increased proliferation of the granulocytic cell line without the loss of their capacity to differentiate. Consequently, the peripheral blood cell profile shows an increased number of granulocytes and their immature precursor, including occasional blast cells. 20% of all leukemias is represented by this type of leukemia, and affects usually only adults. Chronic myelogenous leukemia is the one of the few cancers known to be caused by a single specific genetic mutation. More than 90% of cases results from a cytogenic aberration known as Philadelphia chromosome. It's characterized by a cytogenetic aberration consists of a reciprocal translocation between the long arm of the chromosome 22 and 9. The translocation results in a shortened chromosome 22, an observation first described by Noel and Hunderford and subsequently termed the Philadelphia chromosome after the city of discovery. Chronic myelogenous leukemia progresses through the three phases: chronic, accelerated, and blast. In the chronic phase of the disease, mature cells proliferate. In accelerated phase, additional cytogenetic abnormalities occur. In the blast phase, immature cells rapidly proliferate. Approximately 85% of patients are diagnosed with the chronic phase and then progresses to the accelerated and blast phases after 3 to 5 years. As we already said, that it's 20% of the cases of all leukemia affecting adults, represented by this type of leukemia. It typically affects middle-aged individuals, and commonly the disease occurs in younger individuals. Younger patients may present with a more aggressive form of the disorder, such as in accelerated phase or the blast crisis phase. No familial association in this type of leukemia. The risk of development is not increased in monozygotic twins or in relatives of the patient. No etiological agents are incriminated, and no association exists with exposure to benzene or other toxins, fertilizers, and insecticides or viruses. Chronic myelogenous leukemia is not a frequent secondary leukemia following therapy of other cancers with alkylating agents or radiation. Exposure to ionizing radiation has increased the risk of this type of anemia, which peaks at 10 to 5 years after exposure and is dose related. The median time of the development among atomic bomb survivors was 6.3 years. This type of leukemia results from the malignant transformation of the single hematopoietic cell. The transplantation 9 to 22, 4 to 11 is present in 90% of classical cases. It's present in hematopoietic cells, myeloid, erythroid, megakaryocytes, and monocytes, less often in mature B lymphocytes, rarely T lymphocytes, but not stromal cells. But not in the other cells of the human body except hematopoietic cells too. As a result of translocation, DNA sequences from the cellular oncogene ABL1 are translocated next to the major breakpoint cluster region gene on chromosome 22, generating a hybrid oncogene BCR-LBL1. This fusion gene typically encodes for a novel oncoprotein of molecular weight of 210, referred as P210 BCR-ABL1. This oncoprotein exhibits constitutive kinase activity that leads to excessive proliferation and reduced apoptosis of the Myelogenous leukemia cell, endowing them with a growth advantage over their normal counterparts. Myeloid progenitor cells expand in various stages of maturation and releases prematurely into the peripheral blood, and home to extramedullary locations. The discoverable expansion of the myeloid progenitor cell appears to result from alternation in their proliferative capacity as a shift in the balance between self-renewal and differentiation toward differentiation, increasing the number of progenitor cells and reducing the pool of stem cells. Stem cells become part of the proliferating compartments, causing the neoplastic cell population to expand exponentially in the later maturational compartments, where they may also be less responsive to the growth regulatory signals from either cytokines or the bone marrow microenvironment. The expression of specific cytokine profiles may result in increased expansion of chronic myeloid leukemia progenitor cells. Over time, normal hematopoiesis is suppressed, but normal stem cell can persist and reemerge following effective therapy, for example, with tyrosine kinase inhibitors. Chronic myeloid leukemia is defined by the presence of BCR-ABL1 fusion gene in the patient with the myeloproliferative neoplasm. The clinical manifestation of this type of leukemia are indicious. The disease is often discovered incidentally in the chronic phase when an elevated white blood cell count is revealed by a routine blood count or when the enlarged spleen is found on a general physical examination. Non-specific symptoms of fatigue and weight loss may occur long after the onset of the disease. Loss of energy and decreased exercise tolerance may occur during the chronic phase after several months. Patients often have symptoms related to enlargement of the spleen, liver, or both. The large spleen may encroach of the stomach and cause early satiety and decreased food intake. Left upper quadrant abdominal pain described as gripping may occur from the spleen infarction. The larger spleen may also be associated with the hypermetabolic state, fever, weight loss, and chronic fatigue. The enlarged liver may contribute to the patient weight loss. Some patients with this type of leukemia have low-grade fever and excessive sweating related to hypermetabolism. In some patients who present in the accelerated or acute leukemia phase of the disease, skipping the chronic phase, bleeding, petechia, and ecchymosis may be the prominent symptoms. In this situation, fever is usually associated with infection. Bone pain and fever, as well as increase in the bone marrow fibrosis, are hinders of the blast phase. Splenomegaly is the most common physical finding in the patient with chronic Myelogenic leukemia. The size of the spleen correlates with the peripheral blood granulocyte count, with the largest spleen being observed in the patient with high white blood cell count. A very large spleen is usually a harbinger of the transformation into an acute blast crisis form of the disease and could be present with lymphadenopathy and extramedullary disease, means lymphatic cell appearance in the skin or subcutaneous lesions. Hepatomegaly also occurs, although less commonly than splenomegaly. Hepatomegaly is usually part of extramedullary hematopoiesis occurs in the spleen. Physical findings of leukostasis and hyperviscosity can occur in some patients with extraordinary elevation of white blood cell count exceeding 300 to 600,000 cells in nanoliter. Upon fundoscopy, the retina may show papilledema, venous obstruction, and hemorrhages. There are several phases, as we already talked. Let's talk about them precisely. So in chronic phase, the blood and bone marrow contain less than 10% of blasts. Blast, it's a mature white blood cells. This phase can last for several years. However, without treatment, the disease can progress to be accelerated or blast phases. About 90% of patients with chronic phase of chronic Myelogenous leukemia when represented at the time of diagnosis. Some people with chronic phase may have symptoms when they are diagnosed, or some may not have. Most symptoms go away once treatment begins. In accelerated phase, there is no single definition technical of this phase, but most patients in this phase are represented by from 10 to 19% of blasts in both the blood and the bone marrow, or more than 20% of basophils in the peripheral blood. Basophil with a special type of actually it's a special type of white blood cells. Sometimes may have new cytogenetic changes in addition to the Philadelphia chromosome because of additional DNA damage and mutation in the cells. Blast phase, or called also blast crisis, represented by appearance of them 20 and more % of bloods in the blood and the bone marrow, and it's difficult to control the number of the white blood cells. The blood cell can look like immature cells in the patients with other type of leukemia, especially with acute lymphoblastic leukemia. Patient in the blast phase often have fever, enlarged spleen, weight loss, and generally feel unwell. Resistant chronic Myelogenous leukemia, we can talk about this phase when after the treatment, after some time of the treatment, all symptoms and changes in the blood return to before treatment state, or when the patient has absolutely no response to treatment prescribed. So criteria of accelerated phase historically associated with the median survival include the presence of 15 to or more blasts. Peripheral blast count, 30% or more peripheral blast plus promyelocytes, and 20% or more peripheral basophils. Cytogenetic clonal evolution, presence of chromosomal abnormalities in addition to Philadelphia chromosome, and thrombocytopenia less than 100 in liter, unrelated to therapy prescription. about 5 to 10% present with the no accelerated phase or blastic phase. Blast crisis is marked by an increase in the bone marrow or peripheral blood blast count, or by the development of soft tissue and skin leukemic infiltrates. This is characterized by the blast cells, more than 20% by the WHO criteria and more than 30% by Anderson Cancer Center and International Bone Marrow Transplant Registry criteria. In the peripheral blood smear or the bone marrow, or the presence of extramedullary accumulation of the blood cells, or large foci or clusters of the blast in the bone marrow biopsy. Blasts are normally 1 to 5% of the marrow cell, but normally not more than 5. Remember this number. And large clusters of the blasts are seen in the bone marrow. In case of the blast crisis, the blast cell may have spread to tissues and organs beyond the bone marrow. Typical symptoms are due to increasing of anemia, thrombocytopenia, basophilia, and rapidly enlarging spleen, and failure to send usual medication to control leukocytosis and splenomegaly. These patients often have poor appetite and weight loss. In chronic myelogenous leukemia, if we observe the blood cell count and blood smear, the increase in mature granulocytes and normal lymphocytes count result in the total white blood cell count more than 20 to 60,000 of cells in a liter. A mild increase in basophils and eosinophils is present and become more prominent during the transition to acute leukemia. These mature neutrophils or granulocytes have decreased apoptosis, resulting in accumulation of long-lived cells with low or absent enzymes, such as alkaline phosphatase. Consequently, the leukocyte alkaline phosphatase stains very low to absent in most cells, resulting in the low score. The peripheral blood smear in patients with chronic myelogenous leukemia shows a typical leukoerythroblastic blood picture with circulating immature cells from the bone marrow. The transitional or accelerated phase of chronic myelogenous leukemia is characterized by poor control of the blood counts with myelosuppressive medication, the appearance of peripheral blood cells, promyelocytes, basophils, and reduction in platelet count to less than 100,000 of cells in nanoliter unrelated to TERP. Early myeloid cells such as myeloblast, myelocyte, metamyelocyte, and nucleated red blood cell are commonly present in the blood smear, mimicking the findings in the bone marrow. Bone marrow in case of this type of leukemia is hypercellular with the marked myeloid hyperplasia. Granulopoiesis is dominant and granulocytic to erythroid ratio between 10 to 1 and 30 to 1 rather than normal 2 or 4 to 1. Erythropoiesis usually is decreased, and megakaryocytes are normal or increased in number. Eosinophils and basophils may be increased, usually in proportion to their increase in the blood. Mitotic features are increased in number. Myeloblasts are 5% or less with expansion of myeloid line and its progenitor cells. Megakaryocytes are prominent and may be increased. Mild fibrosis is often seen in the reticulin stain. Increased reticulin fibrosis is common with up to 40% of patients demonstrating grade 3 to 4 reticulin fibrosis. Cytogenetic studies of the bone marrow cells and even peripheral blood should reveal the typical Philadelphia chromosome, which is reciprocal translocation of chromosomal material between chromosome 9 and 22. In addition, hemeric BCR-ABL messenger and RNA that characterize chronic myeloid leukemia can be detected by polymerase chain reaction. Karyotypic analysis of the bone marrow cell requires the presence of the diving cell without loss of viability because the material requires that the cells go into mitosis to obtain individual chromosomes for identification after binding. Chemical abnormalities can be present in patients with chronic myelogenous leukemia includes an increased production of the uric acid with hyperuricemia and hyperuricosuria occurs mostly these changes in untreated cases of disorder. Uric acid excretion often is 2 or 3 times normal in patients with this type of leukemia. If aggressive therapy leads to rapid cell lysis, excretion of the additional purine load may produce urinary tract blockage from uric acid precipitates. Formation of urinary urate stones is common in patients with chronic myeloid leukemia, and some patients with latent gout may develop acute gout T arthritis or uric acid nephropathy. Neutrophils contain vitamin B12 binding proteins, including transcobalamin 1 and 3. That's why patients with myeloproliferative neoplasm have an increased serum level of vitamin B12 binding capacity, and the source of the protein is principally mature neutrophilic granulocytes. The increase in transcobalamin level and the resultant increase in the vitamin B12 concentration are partially notable in patients with chronic myeloid leukemia. Also, an increase in the number of neutrophilic granulocytes is a leukemioid reaction can be accompanied by the increase of the serum vitamin B12 binding protein levels and vitamin B12 concentrations. Mean histamine levels are markedly increased in the patient in chronic phase compared to healthy individuals, and this elevation is correlated with the blood basophil count. Cases of exaggerated basophilia and disabling pruritus, urticaria, and gastric hyperacidity have occurred associated with enormous increase of the blood histamine concentration. The level of serum lactic dehydrogenase level is elevated in patients with chronic myeloid leukemias and other leukemias. And as you remember, LDH levels represents usually the big amount of the cells in the blood which have been destructed. So the breakdown of big amount of cells leads to appearance of high level of LDH, not dependent on its cause. Will it be leukemia? Will it be trauma? Will it be huge myocardial infarction or severe stroke? So it's not specific marker of leukemia, but represents the damage of the big amount of the cells. In case, if we talk about leukemia, they are hyperproduction. Yeah. Pseudo-hyperkalemia resulting from the release of the potassium from white blood cells during the clotting, and spurious hypoxemia or pseudo-hypoglycemia from in vitro utilization of oxygen or glucose by granulocytes can occur. Hypercalcemia or hypokalemia has occurred during the chronic phase of the disease. Serum cholesterol is decreased in patients with this type of leukemia. Angiogenin, endoglin, vascular endothelial growth factor, and beta fibroblast growth factor and hepatocyte growth factor are increased strictly in the serum of the patient with chronic myeloid leukemia. Differential diagnosis should be made with the other chronic hematopoietic stem cell diseases such as polycythemia vera, essential thrombocytopenia, or primarily fibrosis only occasionally have closely overlapping features. For example, the total white cell count is greater than 30 in more than 90% of the patients, and increases inexorably over the weeks or months of observation. Whereas the total white cell count is less than 30, more than 90% of patients with the three other classic chronic myeloid diseases, and usually does not change significantly over the months to years. Polycythemia vera is associated with increased red cell mass and hemoglobin concentration and displays clinical signs of plethora. Chronic myelogenous leukemia does not have these features. Patients with essential thrombocytopenia have a platelet count greater than 450 and usually only mild neutrophilia. The slide neutrophilia distinguishes it from proportion of the chronic myeloid leukemia patient with platelet counts greater than 450, who are at time of diagnosis have white cell count above 25. The Philadelphia chromosomes have been found rarely in the patient with apparent polycythemia vera and polycythemia vera that later evolves into Philadelphia chromosome positive chronic myelogenous leukemia, primary myelofibrosis, and myelodysplastic syndrome. Rare cases of aplastic anemia have presented with BCR-ABL1 positive cells or have evolved into BCR-ABL1 chronic myelogenous leukemia. The goals of treatment of chronic myelogenous leukemia are threefold: to have changed markedly in the 10 last years. So they are follows. First one, it's hematologic remission, cytogenetic remission, and molecular remission. Initial cytoreduction therapy is presented now by tyrosine kinase inhibitor therapy. In cases where the white cell count is markedly elevated, hydroxyurea can be used prior or in conjunction with this type of drugs. If rapid cytoreduction is required because of the signs of hyperleukemic syndrome, leukapheresis and hydroxyurea often are combined. Leukapheresis can control chronic myelogenous leukemia only temporarily. For this reason, it's rarely used in chronic phase and is useful in only two types of patient: the hyperleukocytic patient, in whom rapid cytoreduction can reverse symptoms and signs of leukostasis, and the pregnant patient with chronic myelogenous leukemia. Hydroxyurea 1 to 6 gram daily orally, depending on the height of the white blood cell count, can be used to initiate elective therapy. Urgent treatment of extraordinary total white cell count may require higher doses. The dose of the hydroxyurea should be decreased as the total white cell count decreases, and usually is given 1 to 2 grams a day when the total white cell count reaches 20. The drug should be temporarily discontinued if the white cell count drops below 5. Anagrelide can be used for platelet reduction in patients who present with elevated platelet counts. This agent acts directly to decrease megakaryocyte mass, and it can lead to precipitous fall of the platelet counts. Tyrosine kinase inhibitor, one of the representatives is Gleevec or imatinib mesylatis, and this drug is an inhibitor of abnormal BCR-ABL tyrosine kinase created by Philadelphia chromosome translocation abnormality. Imatinib inhibits proliferation and induces apoptosis in cell positive for BCR-ABL. For patients with chronic phase of chronic myeloid leukemia, imatinib at 400 milligrams daily is the best dosage for primary therapy because it induces a complete hematological response in almost all patients and causes high cytogenetic response rate. With the imatinib at 400 milligrams a day orally in patients with newly diagnosed chromosome positive chronic myelogenous leukemia in the chronic phase, the complete cytogenic response rate is 70%, and the estimated 3-year survival rate is 94%. Imatinib has been found to cause regression of the marrow fibrosis at 3, 6, 9, and 20 months after the initiation therapy. Measuring of the PCR by PCR, the BCR-ABL1 transcription is required. The second generation of tyrosine kinase inhibitors represented by dasatinib, nilotinib, and bosutinib, which they are more potent inhibitors of BCR-ABL than imatinib. Moreover, they exhibit significant activity against the all resistant mutation except BCR-ABL T315Y. Compared with these second-generation agents, imatinib has relatively low potency and inhibits its target as micromolecular rather than nanomolecular concentrations. In addition, imatinib has increased expectability to resistance through the number of mutations in the BCR-ABL target. Salvage therapy in the chronic phase with dasatinib, nilotinib, bosutinib, or ponatinib is associated with complete cytogenic response rates around 60% and depending on the salvage status, cytogenic or hematogenic response prior to response to other tyrosine kinase inhibitors and the mutation at the time of the relapse. Other agents used for treatment of the chronic phase of the chronic myelogenous leukemia includes interferon alpha, cytarabine, busulfan, and also splenectomy. In the past, interferon alpha was the treatment of the choice for patients with chronic myelogenous leukemia who were too old for bone marrow transplantation and who did not have a matched bone marrow donor. With the advent of tyrosine kinase inhibitors, interferon alpha is no longer considered first-line therapy, but may be used in combination with newer drugs for treatment of refractory cases. Cytarabine combination with other drugs in the chronic phase was associated with the greater proportion of positive results at 12 months and greater survival prolongation than solitary therapy with interferon alpha chemotherapy. Once the mainstay of the treatment of the chronic phase, busulfan usage now is rare. It's used primarily as part of the preparative regimen for allografting and autografting. It may be used occasionally in older patients who do not have tolerate tyrosine kinase inhibitors. Intensive multi-drug regimens have been used in the attempt to eradicate of Philadelphia chromosome positive clone and occasionally have led to prolongation of remission or cure of the disease. This approach did not significantly increase population survival. Splenectomy does not prolong the chronic phase of the disorder, delay the onset of the accelerated phase, and hasten sensitivity to tyrosine kinase inhibitors or chemotherapy or prolong survival of the patients. In carefully selected patients with symptomatic thrombocytopenia and responsive to treatment, mechanical discomfort, hypercatabolic symptoms, and portal hypertension, splenectomy may be useful and may help to relieve the symptom. Allogeneic bone marrow transplantation or stem cell transplantation is currently the only proven cure for chronic myelogenous leukemia. Ideally, it should be performed in the chronic phase of the disease rather than in transformation phase or in the blast crisis. Candidate patients should be offered the procedure if they have a matched or single antigen mismatched related donor available. In general, younger patients fare better than older patients. Bone marrow transplantation should be considered early in the young patient who have a matched sibling donor. All siblings should be typed for human leukocyte antigens. If no matches is available, the human leukocyte antigen type can be entered into a bone marrow registry for completely matched unrelated donor if the registry is present in the country, of course. Autologous bone marrow transplantation can be entered into a bone marrow registry, is investigational, but relatively recently, chemotherapy combination or interferon have been found to induce cytogenic remission and allow harvesting of for chromosome Philadelphia negative cluster of differentiation 33 hematopoietic stem cell from the patient's peripheral blood. With patients in the blast crisis who are imatinib naive, naive means have no previous treatment with imatinib, the drug is used in combination with induction regimens similar to those used in acute myelogenous or lymphoblastic leukemia. Most patients with minimal residual disease after transplantation require interferon maintenance therapy. Alternatively, they may require a reinfusion of T cells collected from the donor. Molecular monitoring in chronic myelogenous leukemia is a powerful tool to document treatment responses and predict relapse. The most substantive method for detecting of chronic myelogenous leukemia is a quantitative reverse transcriptase for BCR-LBL messenger RNA, which can detect this type of leukemia cell in approximately 100,000 to 1 million cells. The goal is 100% normal cell after the 1 or 2 years of the therapy. Patients who remain BCR-LBL changes positive should be kept on maintenance therapy as long as they continue to have minimal residual disease. The standard therapeutic milestone to be achieved are follows. At 3 months is complete hematological response, at 6 months minor cytogenic response, at 12 months it's major cytogenic response, and at 18 months, it's complete cytogenic response. So no chromosome should be at the end of the treatment. Failure to achieve these milestones should trigger a reassessment of the therapeutic strategy. Most patients with complete cytogenetic response continue to have PCR findings, means positive on BCR-ABL messenger RNA, indicating the presence of minimal residual disease. Discontinuation of the drug in these patients is usually followed by relapse, suggesting that imatinib fails to eradicate leukemic stem cells in these patients. By prognosis, patients can be classified into the following groups: good risk, immediate risk, and poor risk. Each risk group require the actually average survival. So in the good risk, it's survival, the patient predicted survival. Yes, it's 5 to 6 years. In poor risk, it's 2 years and later. One widely used prognostic index in the SOCAL score is calculated for patients aged 5 to 84 years by the following equation. You can see its hazard ratio, and it correlates actually to these three groups of the average survival risk, name it, patients. Since the advent of the SOCAL score, the two other prognostic scores have been developed. It's Hasford score. You can see on this part of the slide was represented in 1990s, and EUTOS, or European Treatment of Outcome of the Study score, in 2000s. Like SOCAL scores, the Hasford formula characterized patients into low, immediate, and high group of patients after the calculation of the score, which usually represented by the spleen size, platelet count, and number of the blasts in the blood. And the EUTOS score differentiates only between high risk and low risk patients, but the calculation is similar to presented by SOCAL score. Acute lymphoblastic leukemia is a neoplastic disease that results from a multiple-step somatic mutation in a single lymphoid progenitor cell at one of the several discrete changes in the development. The immunophenotype of leukemic cells at diagnosis reflects the level of differentiation achieved by the dominant clone. Etiology can be divided into four major parts, and first one is representative of the viral infection. It's one mechanism of leukomyogenesis and DNA methylation caused by the viral infection. Can be suspected in the appearance of this type of leukemia. The abnormal expression of hematopoietic and proliferation genes persists even after the viral clearance. Also, etiology can be represented by genetic susceptibility, because cases of this type of leukemia with abnormalities of the chromosome band 11 to 23 following treatment with topoisomerase 2 inhibitors for another malignancy have been described. The progression of pediatric acute lymphoblastic leukemia can start in utero or shortly after birth. Rapid growth of the fetus increases the risk of inflicting of acute lymphoid leukemia. High birth weight is an important risk factor for pediatric leukemia appearance, and similarly, gene expression of the insulin growth factor axis also serves an important role. This abnormal gene expression can start in utero or during the early postnatal period, when lymphoid stem cells are immature and therefore increasing the risk of malignant transformation. Benzene is widely present in the work environment, such as the fumes of paint and cigarette smoke, and known as cancerogen. And parental exposure to benzene increased the risk of childhood leukemia. In the liver of a lung, benzene is metabolized to benzene oxide and hydroquinone before further converted to benzoquinone on the bone marrow, where cytotoxicity and DNA damage typically occur. The malignant cell of the acute lymphoblastic leukemia are lymphoid precursor cell. that are arrested in the early stage of development. This arrest is caused by an abnormal expression of genes, often as a result of chromosomal translocation or abnormalities in the chromosome number. These aberrant lymphoblasts proliferate, reducing the number of the normal marrow elements that produce other blood cell lines. Consequently, anemia, thrombocytopenia, or neutropenia occur, also typically to a lesser degree than is seen in acute myeloid leukemia. Lymphoblasts can also infiltrate outside the marrow, particularly in the liver, spleen, and lymph nodes, resulting in enlargement of the later organs. The Prognosis organization classifies all acute lymphoblastic leukemia based on the immunophenotype of the leukemia cells. The immunophenotype is determined by the lab results, including the flow cytometry and cytogenic tests. Rarely, acute leukemia may have characteristics of both acute lymphoblastic and acute myelogenous leukemia. These rare leukemias are referred to the mixed phenotype acute leukemias. B-cell lineage takes more than 70% of adult cases of acute lymphoid leukemia, and the most frequent immunoserological subtype, common acute lymphoid leukemia, is characterized by the presence of ALL antigen and glycoprotein. Common blast cells do not carry markers of the mature B cells, such as cytoplasmatic immunoglobulins or surface membrane immunoglobulins. Pre-B acute lymphoblastic leukemia or early B leukemia is characterized by expression of the cytoplasmic immunoglobulins being negative in common acute lymphoblastic leukemia, but is otherwise identical with all other cell markers. T lineage of acute lymphoblastic leukemia takes approximately 25% of all cases, and all cases express T cell antigen cluster 7 and cytoplasmatic or surface CD3. They may, according to the step of T cell differentiation, express the T cell antigens, Rosetta receptor, and cortical thymocyte antigen. B phenotype of mixed leukemias are defined of those in which markers of lymphoid and myeloid lineages are co-expressed in the same leukemic cell without the typical phenotype of either lymphoblastic or myeloid type. B-lineage leukemias are those with two populations of the blast cells with either lymphoid or myeloid antigens. They must be differentiated from acute myeloid leukemia by co-expression of the lymphoid markers and from acute lymphoid leukemia by co-expression of myeloid markers. There are three morphological subgroups of acute lymphoblastic leukemia, distinguished by older morphological French-American British classification, where the distinction between L1 and L2 morphology has no clinical consequences. The detection of third type is of clinical and prognostic relevance. It's observed in up to 5% of adult patients and should be distinguished as an indicator of mature B, acute lymphoblastic leukemia, usually termed Burkitt leukemia, with distinct treatment options. A surface marker confirmation should be obtained. Uncommon variants can be seen represented by small cell variants. The blood cells are small and may be mistakenly taken as lymphocytes. Hand mirror variants, it's a subtype with the cytoplasmic protrusion. And acute lymphoblastic leukemia with eosinophilia, and granular cell acute lymphoblastic leukemia, where cells are large and demonstrate eosinophilic granules. Patient with acute lymphoblastic leukemia presents with signs and symptoms relating to direct infiltration of the marrow and other organs by leukemic cells. Always signs and symptoms are relating to the decreased production of normal marrow elements. Fever is one of the most common signals and signs of acute lymphoblastic leukemia, and patients often have fever without any other evidence of infection. Patients with this type of leukemia have decreased neutrophil counts, regardless of whether their total white blood cell count is low, normal, or elevated. As a result, these individuals are at increased risk of infection. Infections are more common than absolute neutrophil count is less than 500 in 1 nanoliter, and the especially severe one is less than 100 in nanoliter. Symptoms of anemia commonly include dizziness, fatigue, palpitation, and dyspnea upon even mild exertion. Other patients present with bleeding, which can be result in thrombocytopenia due to marrow replacement. Some patients present with palpable lymphadenopathy, others, particularly those with T-cell type of leukemia, present with the symptoms related to a large medicinal mass, such as shortness of the breath. Infiltration of the marrow by a massive number of leukemic cells frequently manifests as a bone pain. This pain can be severe and is often typical in distribution. Also, patients may have symptoms of leukostasis as respiratory distress, altered mental status due to hyperviscosity, etc., because the presence of the large numbers of lymphoblasts in the peripheral circulation. Patients have commonly physical signs of anemia, including pallor and cardiac flow murmur. Fever and other signs of infection, including lung findings of pneumonia, can also occur. Fever can be interpreted as evidence of infection even in the absence of the other signs. A patient with thrombocytopenia usually demonstrates petechia, particularly on the lower extremities. A large number of ecchymosis is usually an indicator of coexisting coagulation disorder, such as disseminated intravascular coagulation. Signs resulting to an organ infiltration with leukemic cells and to a lesser degree lymphoadenopathy may be present. Occasionally, patients have rashes that result in infiltration of the skin with the leukemic cells. The following studies and procedures are used in the workup for acute lymphoblastic leukemia: complete blood count with peripheral smear, correlation studies, chemistry profile, bone marrow aspiration in the biopsy, culture, in particular blood culture if suspected some infection, to differentiate infection from the acute leukemia, or to help define the different type of infectious disorder as a consequence of leukemia, chest radiography, CT scan if needed, multiple gate acquisition scan or echocardiogram if needed, and lumbar puncture. National Comprehensive Cancer Network guidelines note that the diagnosis of acute lymphoblastic leukemia generally requires demonstration of more than 20% of bone marrow lymphoblasts, morphological assessment on the right or GM sustained bone marrow aspirate smear, hematoxylin and eosine stained bone marrow core biopsy and the clot section, comprehensive flow cytometric immunophenotyping, baseline characterization of the leukemic clone to facilitate subsequent minimal residual disease analysis. For optimal risk stratification and treatment planning for patient with acute lymphoblastic leukemia, this guideline advises that the bone marrow and or peripheral blood lymphoblasts must be tested for specific or recurrent genetic abnormalities as following: in cytogenetics, it's karyotyping for G-banded metaphase chromosomes, interface fluorescence in situ hybridization, advanced transcriptase polymerase reaction for fusion genes, and additional assessment may be considered in cases of aneuploidy or failed karyotype. Peripheral blood counts with a differential count from the right GM sustained blood smear are essential in the time of presentation. The white blood cell count is about 40% of the all acute lymphoblastic leukemia patients is reduced or normal. 1/3 of the patients have a moderately increased initial white blood cell count. Leukemic blood cells in the peripheral blood are largely responsible for the rise in the white blood cell count, but it's not worse than 80% of all patients. No circulating leukemic bloods are observed. Peripheral blood observation shows characteristic of anemia, thrombocytopenia, and neutropenia. The reduction in the level of hemoglobin is usually mild to moderate, but nearly 1/3 of the patients have hemoglobin levels less than 7 grams by deciliter. A platelet count below a critical number of 20 in liter and seen in 1/5 of all patients with this type of leukemia. Bone marrow is pretty important for immunological, cytogenetic, and genomic markers. Direct smear from the bone marrow are essential to confirm the diagnosis of acute leukemia and distinguish it between the myeloid and lymphoblastic types. The bone marrow is usually heavily packed with leukemic blood cells, comprising more than 90% of the nucleated cells in around 70% of the patients. The normal hematopoietic elements are greatly reduced or absent. A biopsy of the bone marrow further demonstrates marked hypercellularity with the replacement of the fat spaces and normal elements by infiltration with leukemic cells. Aspiration slides should be sustained for morphology with either right or GM stain. Here you can see GM stain. Yeah. Here's how it looks like a blast in patient with lymphoblastic leukemia. And the diagnosis of this type of leukemia is made when at least 30% of the lymphoblasts or 20% of the lymphoblasts by the WHO are present in the bone marrow or peripheral blasts. In addition, slides should be sustained with myeloperoxidase or Sudan black and terminal deoxynucleotide transferase unless another method is used, such as flow cytometry. Imagine studies used for differential diagnosis or to find complications of the disorders as just rigorous real signs of pneumonia or different type of the mediastinal mass, in some cases of T-cell acute lymphoblastic leukemia. You can see it represented on this X-ray. It's an increasing of the size of the mediastinum due to appearance of mediastinal mass. Bulky disease is called, and computer tomographic scans can further define the degree of lymphadenopathy in some patients, including those with mediastinal masses. For example, here it's extramedullary hematopoiesis masses in the paraspinal area. The examination of the cerebrospinal fluid is an essential routine diagnostic measure, and there are different options as to when the first lumbar puncture should be done. One procedure is to delay the examination until the remission is achieved in order to avoid seeding the central nervous system by circulating leukemic blood cells from peripheral blood. Earlier recognition of central nervous disease will lead to immediate specific therapy, which is required for such patients. Other clinicians prefer to perform the lumbar puncture before treatment starts, and this procedure is strongly restricted to patients with an inadequate platelet count, an absence of manifest clinical hemorrhage, and without a high white blood cell count. For safety reasons, all patients should receive intrathecal methotrexate at the first lumbar puncture to avoid actually stuck of their medulla prolongata and further complications. More than 95% of cases of the first and second subtype of acute lymphoblastic leukemia are positive for terminal deoxynucleotide transferase. It's not specific for acute lymphoblastic leukemia, but this type of actually transferase is absent in the third type of mature B-cell acute lymphoblastic leukemia type. And this marker helps to distinguish acute lymphoblastic leukemia from malignancies of more mature lymphocytes, for example, lymphomas type. Flow cytometry helps to distinguish B from T variant, and the classic phenotype for B variant is, you can see on this diagram on the right side of the slide. Flow cytometry can also identify whether patients are eligible for certain therapies. For example, some patients have aberrant expression of myeloid markers such as cluster differentiation 13 or 33. Diagnostic workup of the patient with pre-basal acute lymphoblastic leukemia includes flow cytometry that shows that cells are positive on 10, 19, 22, and 33 clusters of differentiation types, and the terminal deoxynucleotide transferase. Cytogenetic abnormalities occur in approximately 70% of cases in adult population with lymphoblastic leukemia. These abnormalities include balanced translocation as occur in cases of myeloid acute leukemia. However, abnormalities of chromosome number are more common in lymphoblastic variant than in Myelogenous. The diagnostic techniques are standard cytogenetic fluorescence in situ hybridization and reverse transcriptase polymerase chain reaction. These methods allow the detection of Philadelphia chromosome lymphoblastic variant with the chromosomal translocation 9 and 22 and 34 and 11 shoulders, and the detection of corresponding BCR ABL1 gen rearrangement. Gene expression profiling, single nucleotide polymorphism, array analysis, array comparative genomic hybridization, and next-generation sequences recognize newly defined acute lymphoblastic leukemia entities with poor prognosis. They are Philadelphia chromosome-like acute lymphoblastic leukemia and early T precursor acute lymphoblastic leukemia. Minimal residual disease is the detection of residual leukemic cells not recognizable by the light microscopy. Methods of determining of this disorder presentation are based on the detection of leukemia-specific aberrant immunophenotypes by flow cytometry, the evaluation of leukemia-specific arranged immunoglobulin or T-cell receptor sequence by a real-time quantity polymerase chain reaction, or the detection of fusion genes associated with the chromosomal abnormalities. Molecular response can be evaluated only for patients in complete cytological remission with one marker or more for analysis of minimal residual disease, and the samples available at diagnosis are followed at specific time points during the course of the disease. Achievement of molecular complete response, molecular remission is the most relevant independent prognostic factor for disease-free survival and overall survival. Patient with molecular complete remission after induction therapy has significantly superior outcome. Differential diagnosis should be made for acute lymphoblastic leukemia in comparison with myelogenous leukemia. So lymphoblastic, it's mainly for children with present lymphadenopathy, mild hepatosplenomegaly, absence of gum hypertrophy, skin infiltration, but with presence of central nervous system involvement, absence of granulocytic sarcoma, but presence of mediastinal mass in T variants of the disorder, and serum muramidase levels usually are normal and good prognosis. Comparing with myelogenous leukemia, where prognosis is bad, serum muramidase is high, mainly present in adult patients without lymphadenopathy, but present hepatosplenomegaly, presence of gum hypertrophy and skin infiltration in morphological variants 4 and 5, and presence of granulocytic sarcoma in some cases. According to the morphology of the cells, lymphoblast and myeloblast variant should be differentiated by bone marrow examination, and they are extremely different. And also, if lymphoblast is negative for myeloperoxidase and Sudan plaque tests, myeloblast is comparatively positive in these cases. Traditionally, the four components of the treatment are induction, consolidation, maintenance, and central nervous system prophylaxis. The overall survival is 34% with a wide variation up to 60%, and the lowest one is 27% due to differences in the intensity of the chemotherapy regimen and the outcome of the stem cell transplantation. Patients require hospital admission for induction therapy, and they require readmission for consolidation chemotherapy or for the treatment of the toxic effects of chemotherapy. Surgical intervention may be required for the placement of the central venous catheter, such as triple lumen, Broviac, or Hickman catheter. Standard induction therapy typically involves either 4 drug regimens, vincristine, prednisolone, and anthracycline, and cyclophosphamide or L-asparaginase, or 5-drug regimen as vincristine, prednisolone, anthracycline, cyclophosphamide, and asparaginase given over the course of 4 to 6 weeks. Using this approach, complete remission obtained in 45 to 85% of patients. Because the most studies have shown a benefit to consolidation therapy, regimen using standard 4 to 5 drug induction usually include consolidation therapy with combination with anthracycline or epidophylotoxin. Patients who receive this regimen induction receive alternative cycles of high dosages of methotrexate, high dosages of anthracycline, and a hyper-CVAD as consolidation therapy. CVAD means vincristine, prednisolone, anthracycline, and cyclophosphamide. Maintenance therapy usually consists from 6-mercaptopurine and methotrexate, a strategy transferred from childhood type of therapy of this disorder. Maintenance therapy consists of prednisolone, vincristine, methotrexate, and mercaptopurine. Should be adapted to immunological subtypes of the disorder, and mature B variant maintenance is not required, and T and B lineage of the leukemia with relapses up to 2.5 years, maintenance therapy is necessary. The field of positive type maintenance should include BCR-ABL tyrosine kinase inhibitor, and most likely the one that was used during induction and consolidation therapy. In contrast to patients with acute myeloid leukemia, patients with lymphoblastic variant frequently have meningeal leukemia at the time of relapse. A minority of patients have meningeal disease at the time of initial diagnosis. As a result, central nervous system prophylaxis with intrathecal chemotherapy is essential. Prophylaxis is essential for several reasons. Central nervous system leukemia is more easily prevented than treated. Once this central nervous system leukemia has developed, it's generally followed by systemic relapse shortly after. The effective prophylaxis also prevents systemic relapse. Several treatment options are available for this prevention. It's intrathecal therapy, it's cranial radiation therapy, and systemic high dose or intrathecal therapy is usually based on methotrexate as a single drug, but combination with cytazine, arabinazide, or glucocorticosteroids are used in some studies. The route of application is generally lumbar puncture. Hematopoietic cell transplantation is an essential part in the strategy of adult acute lymphoid leukemias and other types of leukemia, and the stem cell source, peripheral blood cells, are increasingly used compared to bone marrow. Also, with regard to the donors, there is a shift from spleen donors to matched unrelated donors or haploidentical transplants from relatives. Indication for stem cell transplantation in the first remission are controversial. Autologous stem cell transplantation in first remissions is restricted due to few disease entities and should be done only in patients who are minimal residual disease negative or older patients. For all relapsed patients, an allogeneic stem cell transplantation is the only curative option to date, and it's recommended to all patients in the second or later complete remission. The use of alternative donors allows for most patients to have an appropriate donor. Allogeneic transplantation can also be effective therapy for patients who have experienced relapse after chemotherapy. Patients with lymphoblastic leukemia acute type have a deficiency in the ability to produce normal blood cells, and they need a replacement therapy. This deficiency is temporarily worsened by addition of the chemotherapy, so all blood products must be radiated to prevent transfusion-related graft versus host disease, which is almost invariably fatal for the patients. Packed red blood cells are given to patients with a hemoglobin level less than 7 and high level if the patient has significant cardiovascular or respiratory compromise. Platelets are transfused in a count less than 10 nanoliter. Fresh frozen plasma is given to patients with a significantly prolonged prothrombin time. Cryoprecipitate is given in the patient if fibrinogen level is less than 100 gram by deciliter. Antibiotics are given to all febrile patients, at minimum include a third-generation cyclophosphamide. In addition to this minimum, other antibiotic agents are added to treat specific documented or possible infections. Patient with persistent fever after 3 to 5 days of bacterial antibiotics should have an antifungal antibiotic added to their regimen. Patients with pneumopulmonary complaints will receive an anti-aspergillus treatment. The use of prophylactic antibiotics in neutropenic patients is for patients undergoing induction therapy. Once patients taking these antibiotics become febrile, they are switched to intravenous antibiotics. The use of granulocyte colony-stimulating factor during induction chemotherapy for acute lymphoblastic leukemia is supported by several studies. Tumor lysis syndrome is a potential life-threatening complication that may be seen in patients receiving chemotherapy for acute leukemias, not only for acute lymphoblastic leukemias, and high-grade non-Hodgkin lymphoma. This syndrome is characterized by elevated blood levels of uric acid, phosphate, and potassium, decreased levels of calcium, and acute renal failure. Rapid tumor cell turnover results in the release of intracellular content into the circulation. Uric acid is a terminal catabolic product of purine metabolism on the humans. Our cells consist from the purines because they are part of the proteins, hypomolecules, protein molecules. So breakdown of the protein molecule to appearance of the purine in the blood. Hypocalcemia is a consequence of acute hypophosphatemia with subsequent precipitation of the calcium phosphate in the soft tissues. The kidney is the primary organ involved in the clearance of the uric acid, potassium, and phosphate. Pre-existing volume depletion of the renal dysfunction predisposes patient to worsening metabolic derangement and acute kidney injury. In acute kidney injury, decreased calcitriol levels also cause hypocalcemia. Patients with a high tumor burden, particularly those with severe hyperuricemia, can present in the renal failure. Allopurinol at 300 milligrams 1 to 3 times a day is recommended during induction therapy until blasts are clear and hyperuricemia resolves. Only 20 to 40% of adults with acute lymphoblastic leukemia cured with current treatment regimens. Historically, this patient can be divided into 3 prognostic groups: good, intermediate, and poor risk. Intermediate risk include those with conditions that not meet criteria of good risk or poor risk, and for good risk, it's no adverse cytogenetics, younger age, white blood cells less than 300 nanoliter. 30 in nanoliter. Complete remission within 4 weeks. Poor risk adverse cytogenetics, older age, precursor B cell type, with high level of white blood cells, more than 100,000 nanoliter, and failure to achieve complete remission within 4 weeks. In addition of tyrosine kinase inhibitor to chemotherapy has resulted in improved prognosis of the patient of Philadelphia chromosome. TLNH associated with the younger age, male sex, presence of medicinal mass, high level of white blood cells and hemoglobin level, longer survival, and longer disease-free survival. The number of T markers expressed also have a prognostic significance. Case-specific molecular probes or multiparametric flow cytometry can be used to detect one leukemic cells in 10,000 monoclonal cells, and the presence of minimal residual disease after treatment is a strong predictor for relapse for the patient. And the last type we will discuss today is chronic lymphoblastic leukemia. It's a monoclonal proliferation of mature B lymphocyte defined by an absolute number of malignant cells in the blood. The presence of malignant B cell under this count in the blood without nodal, spleen, or liver involvement and absent cytopenias is a precursor of the disease called monoclonal B cell lymphocytosis, with 1 to 2% chance per year of progression to overt chronic lymphoblastic leukemia. Is the most common form leukemia found in adults in Western countries, median age at 71. Some patients die rapidly within 2 or 3 years of diagnosis because of the complications, but most patients survive 5 to 10 years. In the case of the most malignancies, the exact cause is uncertain. It's a acquired disorder, and reports of truly familial cases are exceedingly rare. The first-degree relative has 8.5-fold elevated risk of developing than the general population. Unlike many other malignancies, there have been no definitive risks between chronic lymphoblastic leukemia and exposures. One of the type of leukemia not linked to radiation exposure, and a sign that it's higher among whites than blacks, among males than females. The cell region, the most patients are clonal B cell arrested in the base cell differentiation pathway, intermediate between pre-B cell and mature B cell. Morphologically, in the peripheral blood, these cells resemble mature lymphocytes. Chronic lymphoblastic leukemia B lymphocytes typically show B cell surface antigen, as demonstrated by 19, 20, 21, and 23 monoclonal antibodies. B lymphocytes express extremely low levels of surface membrane immunoglobulin, most often immunoglobulin M or M and D or immunoglobulin D. Additionally, they also express extremely low levels of single immunoglobulin light chain. An abnormal karyotype is observed in the majority of patients. This type of leukemia has distinct BCR signaling as compared to normal B cells, which is characterized by low level of immunoglobulin M expression, variable response to antigen stimulation, and tonic activation of apoptotic signaling pathways that promote tumor survival. Chronic lymphoblastic leukemia cell by gene expression profile and share many features with the antigen-activated mature B cells, suggesting a role for activation of BCR signaling in the disease pathogenesis. Tumor cells proliferate primarily in lymph nodes and to a less extent in the bone marrow. They where exactly they are in intimate contact with extracellular matrix, T cells, nurse-like cells, follicular dendritic cells, and other stromal cells. The interaction between leukemia cells and this complex microenvironment are mediated by the network of adhesion molecules, cell surface ligands, chemokines, cytokines, and their respective receptors. Leukemia cells organize their supportive inflammatory milieu and promote an immunosuppressive microenvironmental through different mechanisms such as secretion of soluble factors, cell-to-cell contact, and release of extracellular vesicle, amplifying the response of leukemia cells to other signals from the microenvironment and increasing the activation of anti-apoptotic and proliferation of pathways. Tumor release extracellular vesicles carrying non-coding RNA and protein, reducing inflammatory phenotype in T cells, monocytes, and stromal cells. Chronic lymphoblastic leukemia is characterized by dysregulation of the normal immune system in addition to the malignant immune cell. Besides numerical abnormalities due to bone marrow dysfunction, even early stages of the disease, there are skewed ratios of immune cells and functional abnormalities. Inherent immune system detects associated with chronic lymphocyte lymphoblastic leukemia include reduced complement proteins and activity, quantity of neutrophil defects, and functional defects of natural killer cells. The progression of monoclonal B cell lymphocytosis to chronic lymphocytic leukemia is a linear process discriminated by the total number of lymphocytes. The presence of drival alternation is associated with rapid progression. Also, a few alternation that enriched in chronic lymphoblastic leukemia compared to B cell lymphocytosis. Both phases share a similar drive and composition. It's represented in the middle of the slide picture. The main growth dynamics during the treatment phase of leukemia are shown, including spontaneous regression, logistic growth, and exponential growth. So starts from spontaneous regression through the logistic growth to exponential growth. This exponential growth clinically defined as short lymphocyte doubling time and is still considered as adverse prognostic parameter for patients with leukemia. Transformation of leukemia into aggressive lymphoma occurs in 2 to 10% of patients, and in most of them corresponds to high level of blast appear, but Hodgkin lymphoma may also occur. There are two widely used staging systems for chronic lymphoblastic leukemia. It's the Rye staging system, more commonly used in the United States, and the Binet system, more used in Europe. Both characterize leukemia on the basis of the disease bulk and marrow failure. Both rely on physical examination and laboratory studies and do not require imaging of bone marrow because they include the presence of lymphocytosis, absence or presence of lymphoadenopathy, splenomegaly, and hepatomegaly, and presence or absence of anemia with or without thrombocytopenia. Patients with chronic lymphocytic leukemia present with a wide range of symptoms and signs. Onset is insidious, and it's not unusual to be discovered incidentally after blood count is performed for another reason. Enlarged lymph nodes are the most common presented symptom. And seen as up to 90% of patients symptomatic at the time of diagnosis. Predisposition to repeated infections may be noted. Early satiety or abdominal discomfort may be related to enlarged spleen. Mucocutaneous bleeding or petechia may be due to thrombocytopenia. Tiredness and fatigue may be present secondary to anemia. 10% of patients will represent with autoimmune hemolytic anemia. Richter syndrome or Richter transformation refers to transformation of chronic lymphoblastic leukemia into aggressive large B-cell lymphoma and seen in approximately up to 10% of cases. Patients will often present with symptoms of weight loss, fevers, night sweats, muscular wasting, and increasing hepatosplenomegaly and lymphoadenopathy. Patients who do not meet diagnostic criteria based on quantification of the clonal B cells in peripheral blood and who do not have associated signs of lymphoblastic leukemia, including lymphoadenopathy, organomegaly, cytopenias, have a disorder known as monoclonal B-cell lymphocytosis, which is known through to precede every case of chronic lymphoblastic leukemia. Infections are leading cause of the both death-related mortality and deaths in patients with chronic lymphoblastic leukemia. Multiple population-based studies have shown that patients have elevated risk to develop other cancers with the rate up to 3 times that of the general population. The most common cancer type is skin cancer, prostate and breast cancer, and other cancers as well too can be seen. In addition to localized or generalized lymphoadenopathy, patients manifest as following: splenomegaly, hepatomegaly, petechia, pallor. One of the most devastating complications of Richter transformation include clinical signs of which include rapid progression in adenopathy, often specific area, and constitutional symptoms include fatigue, night sweats, fever, and weight loss. LDH level is usually high. In suspected cases, first step is positron emission tomography combined with computer tomography scan to localize an area for biopsy. Standardized uptake values is consistent with chronic lymphoblastic leukemia and can rule out Richter transformation in many cases. Excisional biopsy is diagnostic and needle biopsy should be discouraged. The complete blood count with differential shows absolute lymphocytosis with more than 500 beta lymphocytes in nanoliter. Lymphocytosis must persist for longer than 3 months. Clonality must be confirmed by flow cytometry. The presence of cytopenia caused by clonal bone marrow involvement establishes the diagnosis of the chronic lymphoblastic leukemia regardless of the peripheral B lymphocyte count. Microscopic examination of the peripheral blood smear is indicated to confirm lymphocytosis. Usually shows the presence of smuggled cells depicted in the image below. in the actually not below, but the right side rather there, which are artifacts from lymphocyte damage during the slide preparation. Here they are. Patients with fewer than 5,000 beta lymphocytes in nanoliter with lymphadenopathy and without cytopenias more likely have small lymphocytic lymphoma, so the diagnosis should be confirmed by a lymph node biopsy. Large atypical cells, cleaved cells, and prolymphocytes I also have seen on peripheral smear. If their percentage is exceeded 55%, prolymphocytic leukemia, B-cell prolymphocytic leukemia, is more likely the diagnosis. Bone marrow aspiration and the biopsy with the flow cytometry is not required to all cases of chronic lymphoblastic leukemia, but it may be necessary in selected cases to establish the diagnosis and to assess other complication features such as anemia and thrombocytopenia. For example, bone marrow examination may be necessary to distinguish between thrombocytopenia and peripheral destruction, and then due to bone marrow infiltration. Consider a lymph node biopsy if lymph node begin to enlarge rapidly in the patient with known chronic lymphoblastic leukemia to assess the possibility of transformation to a high-grade lymphoma. When such transformation is accompanied by fever, weight loss, and pain, it's termed Richter syndrome. Patients with this type of anemia do not need drug therapy until they become symptomatic or display evidence of rapid progression of disease, as characterized by the following: weight loss more than 10% over the 6 months, extreme fatigue, fever related to leukemia for longer than 2 weeks, night sweats for longer than 1 month, progressive bone marrow failure, autoimmune anemia or thrombocytopenia not responding to glucocorticoid treatment, progressive or symptomatic splenomegaly, massive or symptomatic lymphadenopathy, progressive lymphocytosis. A patient with low risk disease in whom leukemia is stable require only periodic follow-up. Chemotherapy and immunotherapy are the standard therapy for the patient with chronic lymphoblastic leukemia. For patients who are younger than 65 years, the gold standard for therapy is a combination of nucleoside analog fludarabine, the alkylator cyclophosphamide, and the anti-CD20 monoclonal antibody rituximab. The current focus is on targeted therapy of various combinations. These have already been proven superior to immunochemotherapy alone. At present, chemoimmunotherapy is reserved for young, fit patients with favorable features of leukemia who account for less than 10% of cases. For older patients or those with multiple comorbidities, monoclonal antibody rituximab is not an appropriate option due to toxicity. For these patients, the alkylated chlorambucil in combination with the anti-CD20 antibody obinutuzumab and bendamustine with rituximab are appropriate options. Various combination regimens have shown improved response rates. They include fludarabine cyclophosphamide or rituximab, pentatestine cyclophosphamide or rituximab, for example, or fludarabine cyclophosphamide and mixantron as an example, depending on the patient. Monoclonal antibodies given alone or in combination with chemotherapy was the first targeted therapy to successful treatment of the chronic lymphoblastic leukemia. Trials have investigated the combination of monoclonal antibodies with chemotherapy agents, and rituximab is a single agent that produced only partial response of short duration. But patients with trisomy 12 may express high levels of CD20, this making tumor cells more vulnerable to biological against CD20. The combination of fludarabine and cyclophosphamide with rituximab has shown to produce better clinical response than those seen with either fludarabine and cyclophosphamide in salvage therapy for patients with previously treated lymphoblastic leukemia. three specific targets were the first identified: splenomegaly kinase, phosphoinosine 3 and proton tyrosine kinase, and therapeutic directed in the later two targets have moved forward through the clinical trials and now utilized in clinical practice. So FDA approved recently combination of venetoclax. It's a selective inhibitor of B-cell lymphoma regulatory protein and anti-apoptotic protein, and ipilimumab. It's a CD20 directed cytolytic monoclonal antibody for use in the patient with previously untreated chronic lymphoblastic leukemia. The combination needs to be taken around 1 year only. Also, for patient can be prescribed chimeric antigen receptor T-cell therapy, where T cells are collected via blood sample and transformed in the laboratory, so they will recognize a specific antigen on the surface of the cancer cell and attack the cancer cells and proliferate. Current immune therapy includes allogeneic stem cell transplantation, chimeric antigen receptor T-cell therapy, and oral immunomodulatory agents such as lenalidomide. Stem cell transplantation is currently considered the only standard curative approach for chronic lymphoblastic leukemia. Because most patients are older and may have significant comorbidities, myeloablative transplants incur extensive morbidity and mortality, making them prohibitive in many individuals. Allogeneic stem cell transplant is the only known curative therapy. The optimal timing of transplantation is still being investigated. Refractory splenomegaly and pancytopenia is a common problem for patients with advanced variants of chronic lymphoblastic leukemia. Occasionally, this patient requires splenectomy. All patients who undergo splenectomy should be immunized at least 1 week in advance against pneumococcus, Haemophilus influenza, and Neisseria meningitis. So thank you for your attention. It was a very long lecture. Hope you can survive till the end of it. And traditionally, if you do have any question, please put them in our Facebook page or write on my private email. Thank you very much for being present and have a good day and weekend. Bye-bye.